You can feel anxious without having an anxiety disorder. You can feel exhausted without being depressed. And if you live with chronic illness, a physical symptom can be real, while your emotional response to it is real too. I learned the distinction not from the textbooks, but from my lived experience very early. I was 12 years old when I first began to watch my mother live with diabetes. Later, she was diagnosed with COPD. What made it even more shocking for me was that my mother had never smoked or consumed alcohol. She was a traditional, deeply religious South Indian woman. Smoking and alcohol was simply never part of her life. But I watched her health gradually deteriorate after she was diagnosed with a lung condition, COPD. Over time, her kidney and pancreas also began to suffer, and I could see her overall health slowly declining. Her breathing became harder, her energy began to fade, and over time, I could see her anxiety growing inside her, the fear and uncertainty of not knowing what her body might do next. At that time, I didn't fully understand what was happening with her. I only knew that my mother, who I deeply depended on, is becoming weaker. Years later, as I gained deeper understanding of the disease process through my education and hands-on experience with my patient, I began to see her illness differently. I understood what was happening to her body, and I could recognize the physical and emotional impact of living with chronic breathlessness. But by then, my mother was no longer in a position to hear or accept that perspective. For her, breathlessness and anxiety had become a new normal. They had slowly become part of her identity and the way she experienced everyday life. She had accepted that this was simply how a life is going to be, and that acceptance came with a cost. She became increasingly unhappy, not just with the illness, but with her life and eventually with herself. And I witnessed this. She fought this with resilience. She was pushing herself every day, even during a career and also after retirement. Eventually, after living with these challenges, I lost her at just 62 years old. For the final 4 months of her life, she was in coma. Watching someone you love go through that and you being unable to change the outcome is something that stays with you forever. A journey changed the way I think about health, illness, and the things we take for granted. And this is why I want to share a story. And after more than 2 decades of working with people with chronic respiratory disease in pulmonary rehabilitation, I saw the same intersection again and again. I met people living with chronic breathlessness in my pulmonary rehab session, in my oxygen therapy sessions, in my education sessions in the communities. And whenever I traveled around the world for my conferences and presentation, I saw people struggling with breathlessness. For some, breathlessness had become more than a symptom. It had become a way of organizing their lives. How far could they walk? Could they climb the stairs? Could they go shopping? Could they go out with family? Could they do something without needing to stop? Some were talking about life as though every day was a bonus. And that changed how I think about the relationship between physical symptoms and emotional experience. Because when you live with chronic illness, the question isn't always, is this physical or is this psychological? Sometimes the answer is both. So, where's exactly the line between emotion, feeling, mood, symptom, and disorder? In part one, I explore the complex distinction between emotion and feeling. I introduce William James and Carl Lang, Antonio Damasio's work on bodily states and conscious feeling, and Lisa Feldman Barrett's constructionist account of emotion. These approaches do not give us one universally agreed definition of emotion. They offer different ways of understanding how brain, body, perception, cognition, and conscious experience come together. In this video, I take that distinction out of laboratory and put it in real life to make sense of anxiety, depression, and breathlessness. Hey there, if you're new here, I'm Dr. Devi Sundar, an integrative mind-body consultant. And my channel, Breathe and Thrive, I break the science behind breath, mental health, and chronic illnesses. If you're new here, please hit that subscribe button so you get notified on my weekly content and monthly webinars. And for those who are already subscribed, thank you for your support, and this means a lot to me. And without any further ado, let's dive in. Imagine you have an important presentation tomorrow. You start thinking about everything that could go wrong. Your heart rate increases, your muscle tense, your breathing changes, and your attention narrows onto the threat. And you think, I'm anxious. That is a conscious experience, a feeling. But there is a much larger process around it: anticipation, threat related thinking, physiological arousal, changes in attention, and possibly behavior, such as avoiding the presentation. So I feel anxious describes one part of the experience, not the whole process. And here's the distinction that matters. Feeling anxious does not automatically mean you have an anxiety disorder. Anxiety becomes a clinical question when we're talking about a persistent and a clinically significant pattern of symptoms, including distress and interference with everyday functioning, depending on the specific diagnosis. Feeling anxious before an exam, an interview, or a difficult conversation can be completely real without being pathological. Anxiety is not just something happening as a thought in your head. Emotional states can be accompanied by measurable changes in your body: heart rate, breathing, muscle tension, sweating, dizziness, and your gut sensations. This is where interoception becomes important. Interoception is the brain's ability to sense and represent the body's internal state. Demisio's work helped to highlight how bodily states are connected with feeling and conscious experience. Your brain is constantly receiving information from your heart, lungs, gut, and muscles. So when someone says, "My heart is racing," "I can't get my breath," "my chest feels tight," or "I feel dizzy," those experiences are not imaginary. They are experiences occurring in a real body. The brain's sensing of the body's internal state, and this becomes especially important when someone already has chronic illness. Now imagine someone living with COPD. They become breathless, that breathlessness as a physical basis. But then they become frightened by the sensation. What if I can't get my breath? What if this gets worse? The anxiety increases. The attention becomes more focused on their breathing. The sensation becomes harder to tolerate. The point is not that anxiety caused COPD. It didn't. The point is that physical illness and emotional experience can interact. Research supports how common this overlap can be. A systematic review by Romanesso and colleagues examined 329 studies looking at anxiety symptoms in medically ill adults. The review confirmed moderate or severe anxiety symptoms were common across many chronic medical conditions, including cardiovascular, respiratory, neurological, endocrine, and musculoskeletal disease, as well as cancer and other illnesses. Among specific anxiety disorder, generalized anxiety disorder was the most frequently reported. The important point is that anxiety is common in medically ill population, but it can also be overlooked or inadequately treated. The authors therefore emphasize the importance of recognizing and assessing anxiety in people with physical illnesses. But there is an important scientific caution here. That does not prove chronic illness causes anxiety or that anxiety causes chronic illness. The relationship can be more complicated. What matters clinically is that emotional burden coexists with physical disease and can affect how a person experiences daily life. After watching my mother struggle with breathlessness and over years of working with respiratory patients, I saw people begin planning their life around breathlessness. Chronic illness also creates a difficult diagnostic problem because some physical symptoms overlap with the symptoms that occur in anxiety or depression: fatigue, poor sleep, difficulty in concentration, changes in appetite, pain, breathlessness, and palpitations. These are real experiences, but they have multiple causes. So you cannot look at one symptom and simply say, "That's anxiety, that's depression." You have to look at the whole picture: the medical context, the pattern of symptoms, their persistence, the person's distress, and their effect on functioning. There is another distinction that matters for people living with chronic illnesses. Having a genuine medical condition doesn't protect you from health anxiety. And experiencing health anxiety doesn't mean your illness is imaginary. A systematic review by Lebel and colleagues examining 401 studies found clinically significant illness related fears in more than 20% of patients overall, although prevalence varied considerably depending on the condition and how anxiety was measured. These fears tended to be persistent over time and were associated with poorer quality of life, and this makes intuitive sense. So, if someone with real medical condition says, "I'm frightened about my health," we should not automatically dismiss that fear. Sometimes the scientifically accurate answer is both illness and anxiety can coexist. The same logic applies to depression. You can feel sad without having depression, I mean clinical depression. "I feel sad" describes a subjective experience. Major depressive disorder is different. According to DSM-5, it is a clinically defined syndrome involving depressed mood or loss of interest or pleasure, together with additional symptoms that persist over time and significantly affecting the functioning of the person. And chronic illnesses can make the distinction harder. Someone may be exhausted, sleep poorly, experience pain, or struggle to concentrate. Those symptoms may be related to the physical illness. They may occur alongside the depression, or both may contribute. That is why one symptom rarely tells the whole story. And this is why I think five terms are particularly useful to keep separate. Emotion is the broader process involving multiple symptoms. Feeling is the conscious subjective experience. Mood is a longer lasting affective state. A symptom is a feature or experience that can occur in illness or disorder. And a disorder is a clinically defined pattern that meets established diagnostic criteria and is associated with clinically significant distress or impairment. These concepts overlap, but they aren't interchangeable. And chronic illness shows us exactly why that matters. So again, if you feel anxious, that does not automatically mean you have an anxiety disorder. If you feel sad, that does not automatically mean you have a clinical depression. If you experience a physical symptom during anxiety, it does not make the symptom imaginary. And if you have a chronic illness, psychological and physical process can interact without one cancelling out the reality of the other. Maybe the more useful question is not, is this physical or psychological? Maybe it is, what processes are interacting here? Because that question leaves room for the disease, the symptom, the emotion, the fear, and the lived experience of being inside that body. And for me, this is not just science. I watched my mother live inside that system, and later I watched my patients live in the same system. Behind every symptom is a person. Behind every diagnosis is a person. And behind every feeling is a person trying to make sense what is really happening inside their own body. So instead of asking only, is this physical or psychological, we can ask what is happening in the body, what is happening emotionally, what is happening in the brain, and how are these processes interacting. Sometimes the answer is not either or, sometimes it is both. And understanding that does not make physical symptoms less real or emotional experience less real. It gives us a complete picture. And that's why these distinctions matter. And that process doesn't happen in isolation. What we have learned, what we have experienced, and the culture we live in can all influence how we interpret what our body is telling us. And if you haven't watched part one, go back and watch first because it provides foundation for this part two video. Until my next video, as usual, stay curious, stay healthy.